Good afternoon. It's a pleasure to bring some thoughts about amputation surgery or amputation care to you. Because as you will see, amputation is now and then a very important factor in orthopedic and plastic surgery. So it's been 10 years now since the Boston Marathon bombing, which made up a great group of people in Boston to confine the amputation care there and to bring forward the amputee matters. But there are different reasons, and you can see that the reasons for amputation are not only trauma, but also tumor and vascular or even failed surgical procedures. And amputees are a very, very diverse patient selection. I think every one of you has seen amputees or amputation that has done surgeries. You may lift your arms who has experienced amputation in the surgery theater. So it's a diverse population. So if you take a look at this amputation heights, so there's hip, femur transfemoral amputation, knee exarticulation, and below the knee there's different mobilities when we are considering the different ages of amputees and different etiologies of the amputation. So, okay, this is the wrong direction. When we consider macro amputation, which is meant for a big joint that is replaced by artificial joint, you see, and this the health data from Austria, but maybe this is very, very similar to other countries. The accident 60%, vascular 25%, diabetes, less tumor, and other things. What do you think an amputee has to bring along to be satisfied with the new situation? So these are the personal adjustments. We need them for the amputee to find himself in a new situation, and we know that a positive attitude, humor, spirituality, and psychological strengths are very important factors for an amputee, at least to improve. And if you take a look at these potential factors that influence the adaptation to an amputation, you also see that you need the positive meaning and the amputation-related body image to be lucky with that. But there are two important things that we may be able to adapt surgically. These are phantom limb pain with a strong correlation to adaptation of amputation, and the activity restriction, which is also strong, related to problems. So this is Benjamin K. Potter. He's in Walter Reed's in Bethesda, a military soldier and surgeon, and he did a lot of amputations. And this was while having a lecture at the academy. And this is a really true and important fact. Amputation surgery seems to be simple with expected results and less sexy than reconstruction work in other orthopedic surgeries. But amputation surgery is very complex and nuanced with high complication rates. What does this mean? Yeah? So we had a lot to do to improve amputation surgery. We did a review a couple of years ago with advanced techniques in amputation surgery, and we collected different parts of this surgical factors. So surgical techniques, bone-anchored prosthesis, nerve techniques like targeted muscle reinnervation or regenerative peripheral nerve interface. There was a lot of prosthetic technology and bionics. So all these were journals that were published 5 years ago and for the period of 5 years. So you can see the importance in the literature. In this lecture, I give you some thoughts about bone-anchored prosthesis and nerve techniques, and a bit of bionics. So these are already known techniques that may be important. And has any one of you seen an Ertl? You did? Anyone else? Yeah, so there are a couple of fellows that who did, but we don't have any evidence of this. This is done to improve, but we know very, very few evidence that this really improves outcome of amputees. But there is a randomized control study at the moment running in the US, and they may see some advantage of this. All we know is the shorter the stump, the better for this kind of Ertl technique. Again, it's going fast. The next technique that is interesting and already known is adductor myodesis. You should assume that the shorter the stump in a transfemoral amputation, the more important the adductor quality and the more you lose about this. So if you have a very short transfemoral stump, you should use adductor myodesis. There are different techniques described. You can read them. What does it improve? For an easier prosthesis fit, people walk better and have less flexion and adduction hip deformity. The very important thing for amputees is pain. And we made this study of patients who had their amputation more than 20 years ago, because we are tumor clinics, so we only included patients with a tumor in their history. And 70 to 80% of these patients, even more than 20 years after their surgery, had problems with pain. There is stump pain, there is phantom pain, and this is a really, really important thing. And you can imagine they had a very long history of different medications, of different therapies against them, and still the problem is there. So what can we do about neurologic pain? You think about any?
What we try to do is when we cut the nerves, we have to a lot of deep inside, not to avoid the neurinoma after that. This is one to cover it with muscles, not to be in contact with the bone as air.
That's true. Yeah. So in the history, we cut the nerve to get rid of neuromas and bear it into muscle. So this was an interesting thing, but somehow the outcome was not really clear. So in some cases, the nerves found some kind of muscle attachment, and then maybe no neuroma grew. And in some cases, or more cases, the neuroma grew. So, but there were interesting colleagues like Greg Dumanian, who found that when he did this targeted muscle re-innervation in the upper extremity, with the thought of making potentials to control an electronic arm, he made the experience that these patients didn't have any pain problems. So this was occasional observation by him. So he thought it would be an interesting technique to use it in the lower leg as well, and maybe it would be better. And so he did this first randomized controlled trial with the result of 3.3 lower odds for residual limb pain in patients who had this targeted muscle re-innervation. And Valerio, a Bostonian who does a lot of different nerve techniques, made this study with phantom limb pain and residual limb pain. And you see the NRS scores, yeah, in patients who had general and not TMR. They had higher scores than the patients with TMR. So this is a very good technique, not only for patients with neuroma in a secondary, in a revision case, but also as a primary tool. And there are different possibilities, different colleagues were describing techniques. So you can use the tibial nerve to adapt to the FDL and to co-adapt with TA and PL for the common peroneal nerve in the below knee amputees. And there are techniques that describe also this technique in the transfemoral amputation. Yeah? So just to see how this works, you need to have the nerve, and you need to have a motor entry into the nerve, and you co-adapt this nerve to this motor entry. So you, in fact, lose a part of the natural motor activity. So you have to keep that in mind. So another colleague from the US, Paul Saderna, thought about this. I don't want to lose motor activity. I just want to have some additional motor activity. So he made this generative peripheral nerve interface, RPNI. What about this? He made a kind of muscle sushi, which must not be bigger than 1.5, 0.5 and 3.5 centimeters, because it would be necrotic then and would make wound disturbance. And he buries it, the nerve, the cut nerve, into this muscle sushi in a special technique. And then his thoughts were to make a new muscle potential about this. But this is not really true. This aim was not really succeeded. But on the other hand, this is also a very, very strong technique to avoid phantom limb pain. There's another nerve technique. Yeah? Imagine an amputee walking in a dark room. He doesn't have his eye to constantly fix anything and to control, so he will maybe stumble about that. So because he doesn't have feeling in his leg. Yeah. This is one technique by Gardetto describing a kind of sensory feedback, yeah, by cutting the infrapatellar branch of the saphenous and bearing the sural nerve into this area. So these patients feel actually their heel in this area. And there is a company who uses that with a kind of app, and they can have a sensor in the sole of the feet, yeah, and with vibrotactile function, bringing the pressure of the feet onto this area. And they know how to sense the ground. The interesting thing is that they also tried to use this technique without this saphenous and suralis branch, and this also worked. So also the vibrotactile function on this area makes the patient feel the ground. All right. So, do you have any questions about neurotechniques and pain management of amputees? If not, I will go ahead. Yeah, please.
Works on the traumatic amputations.
How it works?
Yes, in the case of the traumatic amputations, where the nerves and the muscles are really injured and swollen.
True. This is something you have to see. Yeah? If there is a nerve damage and if there is muscle damage, you have to decide. Yeah? Can you use one of these techniques or can't you use? At least there is the chance to cut the nerve and bury it into the muscle. But if you have the chance to use one of these techniques, the patient will profit from that. Okay, if there are no questions about pain, I will go further with the mobility. So the second most strong problem of amputees is the connection of the stump to the shaft. This is the interface. Yeah. And these are the problems that occur there frequently. Pressure ulcer, perspiration, missing proprioception, symptomatic neuroma, no movement control, missing kinesthetic feeling, bacterial overgrowth. These are all problems that occur. So 20 years ago, Bronnemark had the idea of implanting kind of implants into the bone to bear the teeth. This was the father of Richard Bronnemark, who thought about the idea of his father, making it possible to implant some kind of weight-bearing, bone-anchored prosthesis transfemoral and transtibial, so to bigger bones. Per Ingvar Bronnemark, the father of Richard, had this just by chance. So he saw in an experiment that was thought about something different, that titanium really grew into the bone of a cadaver experiment of animals. So the idea of putting something into the bone that attaches to the bone really strong was this by chance invention of him. And nowadays we know a lot of principles when we put something into the bone. So the stability depends on different implant designs. Yeah? So implant length, diameter, form. So there are press fit implants at the moment. There are screwing implants into the bone. And all of this have the aim to be fixed to the bone. Yeah? We knew the texture, the form, the surface, the trabecularity, yeah? The porosity, yeah? And the skin quality is an important thing because you will see there are different philosophies of different implants that we stuck into the bone. And there are different parameters that are important for the outcome of these bone-anchored prostheses. You have the bigger diameters that reduce the peak stress in the cortical area. You have the higher length, the reduction of peak stress in the trabecular interface. And you have this fine thread screw. The more surface contact, the better the bone quality. So this was the invention of the Bronemax. You can see there are a couple of implants nowadays, but not all of them are really high frequently used. So what is high frequently used? It's the Opera. This is the screw implant from Sweden. It's about 20 years now since the first transfemoral amputee was provided an implant. And the other implants you see more press fit. Yeah. And this is the Opera. Has any one of you seen this kind of implant? Nobody ever seen? Okay. So this is a screw implant threaded with titanium with a biohelix. Yeah. Pardon?
That implant we have seen, but not in amputation we use.
Okay.
Only in the implant because it's from Swiss produce what they use in dental.
Yeah, in Sweden. Yeah.
Not Switzerland.
Ah, okay. So the implant is constructed by the fixture, which is put into the bone and growing into the bone. And then the abutment, which is stuck into this fixture and fixed with a screw, the abutment screw. And this is the ILP, another important, at least in Europe and US, important implant. This is the Badal X. It's coming from Netherlands now. But it is derived from the very old German press fit, and they didn't continue because they had fractures of this stem, and this was chrome molybdene. So from Holland they changed it into the same shape, but with titanium. And this is what they use now, and which also is used in HSS by Rotsprach with a press fit. You can also use this screw implant in the upper extremity. This is a patient who was provided this in Vienna in a co-production with Assmann from plastic surgery. So we had this thread cut. Yeah, you see this. You can make this thread, and you see it here in the bone. Then put in the fixture into this pre-cut thread. And this was the result. In the first 2 weeks there was hematoma, you see a very, very dry pin coming out here. Yeah? And this is this Swedish system, the opera system, which is a really important technique. The first is, of course, to put in, this is the orthopedic part of it, to put in this fixture with this thread cut. And the second is the soft tissue management, which is really, really important. You take all the fascia, in this case, you put away the fat tissue, and you lay the skin right onto the bone, and it grows there. So you have only a very, very small canal going into the deep. And this is a very different technique to the press fit implant, where you don't have this attachment of skin to the bone, but you have the subcutaneous fat attached in a kind of interface of the implant and the subcutaneous tissue. So, and here the result with his Vincent hand. Yeah. And this is the other press fit implant. In a transfemoral patient, you have this reaming. This is very fast done, and then you put it into it, and this will stay out. And this implant you can do in a two-stage procedure, in a one stage. So you put it in, make the hole, and the patient can step on his feet 2 weeks after the procedure. This is really fast. There are a couple of other interesting implants like this one with at the compress. You may have heard about this, because this is also in limb salvage, an interesting intercalary implant that is used to improve the strength of the bone here. And there are different other implants, like this was Keep Walking Advanced. This is not a bone anchored prosthesis that is coming out, but this is a staying in, but with less shear forces and to have a better shaped stump. What are the surgical indications for these? What do you think? Should we put it into every amputee, or what do you think?
We should consider the density of the bone when we're putting the implants.
Yeah. Very important factor. Yeah. We usually have not a strong bone in amputees, because of they do not walk really on their legs, so they have a diminished cortical mass and bone mass. A very important thing.
I think best candidates are young people with trauma. I think that they are the best candidates, I think.
Yeah, why do you think that?
Because in my country we have a lot of amputation for patients with vascular problems, chronic vascular problems, or diabetes legs. And for them the soft tissue and the bone are so weak, so I think we have the opportunity bigger to fail and not have a success. So I think the best candidates are young patients with traumatic injuries.
Yeah, very true. What you say, because you have a couple of complications with these implants, and you will see afterwards I have some diagrams where I show you the percentage of complications. So you need to have patients and amputees that are very healthy, to avoid these.
Depends on the quality of bone and soft tissue.
Yeah.
It's very important, I think.
Yeah, true. Anything else? Where?
Because I think one of the complications that we see, for example, if we put external fixation, are the pin infections.
Mm.
We're putting something that is
True.
the half
That
is
it-
out and half is inside. So we have to take care about the
Yeah,
infection.
that's very comparable. Yeah, with the pin infections of extra medullary structures. Yeah. Anything else? What do you think?
Make the patient who wants to have more activity, to help him to get high activity back to his
Yeah.
almost normal.
True. Yeah, we'll see some pictures then, where you see exactly this fact. Yeah.
I have
To-
a question now, Dr. because I was thinking about, for example, if in the emergency department came a patient with trauma of the lower limb that maybe we would think that needs amputation, can we do at the same procedure the implant? No, I think no.
What do you think? No.
Yeah, I'm thinking no.
We can do it. Yes.
You can do it,
But
I'm just thinking now.
does
because
does it make sense? Yeah.
It doesn't make sense because all tissue are damaged. Maybe we have to wait to soft tissue recovery for 2 or 3 months or 6 months, depending.
Yeah. What you are arguing is that the shaft, which we are using since long history, is worth nothing. Yeah? But it is. Yeah? In many cases, a shaft is good. Yeah? And patients rely on that and like a normal, conventional shaft. And it's much more cheaper than this. So it's true what you say, that starting with a normal supplement is the best way we can go. Yeah? What would you say, where would you see the most or the biggest difference in the supplement of a kind of new prosthesis in patients who are not really working with conventional? Do you agree with that? Yeah. What you can see is data from Germany. Yeah? This is the difference of mobility between socket prosthesis and bone-anchored prosthesis. Would you have expected that? There seems to be no difference. Why is that? You said some very important things before. If you do bone-anchored prosthesis in any patient, you will not have a difference. But if you do it exceptionally, like you said, in patients who are very poor with their mobility, and more or less wheel-bound chair bound, then you may have a difference. So this work shows that it's not a therapy for all, and should be exclusively done in patients who really need it. Yeah? And this is the conclusion of a review from the Netherlands. There is a need for a standard set of instruments. There was limited evidence that bone-anchored prosthesis resulted in higher quality of life, function, and cavity levels than socket prosthesis in patients with socket-related problems. So we need patients to supply with these implants with socket-related problems. This is very important. So Johannes Floors, he ran the 100 meters in about 10 seconds, fastest running amputee alive. Yeah. Do you think he's an indication for a bone-anchored prosthesis? Yes? Okay. I don't think, personally. No, because he's already running.
Oh, I thought this. Oh, I thought this was already.
No, without. No.
Okay.
He probably doesn't need bone ankle prosthesis. He's doing his job great. Yeah. So I collected some literature to see which patients were supplied with bone ankle prosthesis. So these are very actual ones. Yeah? Both of them highlighting the press fit system. And what about age? So these patients were around 50 in both of these literature pieces. The BMI, 28, 26, about. Little overweight. Yeah. Yeah. Years after amputations, around 10 years. So this is the answer how surgeons are doing this nowadays. Yeah. So not right after, but if the patients do really have problems with their stumps. And the etiology, different, but most of them trauma, like you said. That's your indication.
We see every day trauma like this. And
Yeah.
What to say?
Yeah. But also surgical complications, cancer, and even infection. Yeah, in some cases. This is really impressive. Yeah. This is literature from also the US. This is the hip adduction angle, as you see it here. Yeah.